Hi, I'm Matthew Sherwood, a cardiology fellow at Duke, and today I'm here with Dr. Michael Ho, a staff cardiologist at the Denver VA and the principal investigator for an interesting trial being presented for post-MI care here at AHA 2013. So Dr. Ho, would you mind discussing with me the reasons for the design of this trial and the rationale, given previous work by Nitish Chowdhury and others in providing medications for free?
Sure. So, there's been limited literature on interventions to try to improve medication adherence after patients are hospitalized for acute coronary syndrome. So we actually set out to do this study about 5 years ago, trying to see if we could figure out a strategy to try to improve adherence rates because they've been so poor in general.
Excellent. So as we move forward with the design of that trial, what do you think are the main results from your trial, and how do you think they'll change clinical practice going forward in our patients that suffer myocardial infarction?
So, the one thing about our trial was that it was a multifaceted intervention. So it incorporated collaborative care between a pharmacist and the patient's primary care physician or cardiologist. It entailed medication reconciliation and tailoring right after hospital discharge. Also included education as well as these automated telephone reminders. So, and in the study we showed that patients in the intervention group had there was a higher proportion of patients who are adherent to their medications. And so I think these results suggest that there may be ways that we can try to improve adherence for patients with their cardiac medications, and this may entail different strategies because the reasons for non-adherence will vary over time.
And may I ask, was there any difference in short and medium-term cardiovascular outcomes with this increase in adherence in medication?
Yeah, so there was not a difference in terms of the clinical outcomes for the proportion of patients who achieved blood pressure or LDL goals, and there's no difference in the proportion of patients who are hospitalized for MI or revascularization and death. One of the limitations of this study is that it was a pretty small study. There was only 253 patients enrolled, and I think additional studies are needed to try to see if that change in adherence leads to improvement in clinical outcomes, and or we should follow these patients longer.
Well, it's hard to deny that better adherence to medical therapy would probably be better for all of our patients after myocardial infarction. I want to thank you very much. And to hear more about late-breaking clinical trials here at AHA 2013, please tune in to the Duke Cardiology Fellows blog.